Hello, everybody. I'm Alexander, and I will be your host for today's webinar on the topic of applied invasive coronary physiology for diagnosis and tailored treatment for coronary microvascular disease. These are our chairs and our speakers. I'll just make a quick introduction about the company of the MDPI. It's a pioneer in scholarly open access publishing and has been supporting academic communities since 1996, based in Basel, Switzerland. We have over 400 peer-reviewed journals and are supported by more than 100 academic experts who share our mission, values, and commitment to providing high-quality service for our authors. And about our journal of JPM, it's the Journal of Personalized Medicine and the International Open Access Journal aimed at bringing all aspects of personalized medicine to one platform. It publishes cutting-edge, innovative, preclinical and transitional scientific research and technologies related to personalized medicine. Okay, that's all for me. I'll leave the floor to Dr. Sabo.
Yes, so welcome everybody in our webinar where we would like to then discuss clinically relevant questions about invasive physiology assessment of the microvascular system. My name is Gábor Tamás Szabó, and I'm interventional cardiologist with strong interest in clinical and preclinical coronary physiology. Together with my colleague Zsolt Kőszegi, we moderate the discussion today. So let me introduce our program and speakers. First of all, my co-chair Zsolt Kőszegi, an excellent interventional cardiologist with precise knowledge and important publications in the invasive coronary physiology field. Zsolt is my former PhD supervisor, and we share our scientific interest, and we published many articles together. And recently we are editing a special issue in the Journal of Personalized Medicine published by MDPI, and we would like to also advertise now the submission here as well. So back to the program. We have two excellent speakers today. Thank you very much that you accepted our invitations. Our first speaker is Zsolt Pirot from the Götzegen Hungarian National Cardiovascular Center from Budapest, Hungary. Zsolt is an interventional cardiologist as well and serves as a deputy head of the adult cardiology department in his institution, besides official current and former positions in the Hungarian Society of Cardiology and the European Society of Cardiology as well. Zsolt is an expert in coronary physiology. His practical knowledge is summarized in many publications. And if I might highlight just one of them, he is a co-author of the paper detailing the results of the FAME2 milestone study, and he was one of the most successful recruiter and also PI in this trial. Our second speaker is Hyung-Sen Fan, an interventional cardiologist working in the Department of Cardiology and Institute of Myocardial Injury and Repair at the Wuhan University, China. Thank you for your contribution to our webinar today. Hyung-Sen recently published an article in the above-mentioned special issue in a collaboration with Professor Tu from Biomedical Instrument Institute, Shanghai. So I think we can start. So dear Zsolt Pirot, the stage is yours.
Thank you very much, dear Chairman. Ladies and gentlemen, it's a privilege for me to participate in this meeting and present some data on the invasive assessment of coronary physiology. And especially in microcirculation. I hope you can see my screen. So traditionally, we have a framework of the epicardial and the microvascular compartment. We only know too well the epicardial, which is precisely described by fractional flow reserve. But recently, we turn our attention to the microvasculature. Of course, we have the coronary flow reserve, which has been there for decades now, but it's not specifically describing the microvasculature. And it also has the well-known problem of relating maximal flow to basal flow, which of course is not very well defined. However, about 20 years ago, the IMR has been described by Professor Fearon and colleagues, and there have been novel steps in this field as well. But we also have to realize that the macro and the microcirculation as such are not just entities on their own, but they are actually comprised of several different entities, like the prearterioles, arterioles, capillaries, and also the venous system is there, which all have their different roles and their different functions and in regulating coronary flow to the microvasculature. to the myocardium, sorry. Recently, we also have been able to delineate different phenotypes of patients with angina pectoris, because traditionally we've been taught to think about structural abnormalities in the epicardial compartment only, and those who were good candidates for revascularization came to our cath labs and had their our arteries or blockages fixed. But recently we realized that it's not only structural, but also functional abnormalities pertaining not only to the epicardial, but also to the microvascular compartment. And these have been described in many publications, and we know that there are overlapping syndromes and so forth. So the first question for us today is how to measure flow in vivo. Where the first thing we had at hand was Doppler flow velocity. We only know that the Doppler effect is well applicable to the coronary physiology. We know that the frequency shift area actually relates to the flow of the red blood cells in the arteries, and there have been catheters developed in that respect, which are able to catch the frequency changes and give us images like this, where the average peak velocity is measured both at baseline and at peak hyperemia, and the quotient of those will give you CFR, and also, of course, FFR can be measured by these systems. There have been a number of problems hampering the wide application of this technology, mostly related to technological issues like the location of the sample volume, which precludes precise measurement and repeatable measurements in about 20 to even 30% of the cases. So the advantage of Doppler measurements is that it's normalized to myocardial mass, but the disadvantages include highly sensitive nature to location of the sample volume. It needs operator skills, and it's also difficult even for well-trained operators to perform these measurements in tortuous vessels. So basically today, this technology has become obsolete, and with the exception of some research laboratories, the Doppler is not used anymore for coronary microvascular assessments. On the other hand, we have thermodilution at hand, but the prerequisites are important for us to realize, and these have been described almost 60 years ago, and we have to keep those in mind, that we need a complete mixture of the indicator. We should exclude the possibility of heat exchange with the adjacent tissue. We should have constant flow during measurement, no recirculation of flow during measurement, and also that the indicator, the injection of the indicator should not influence flow. And if that is given, we have systems like this, whereupon the guiding catheter is entering the coronary at hand or under study, and the pressure wire, the Abbott's pressure wire, which also is a temperature wire, precisely measuring temperature to 0.01 degrees centigrade, is placed distally in the coronary of interest, and the pressure measuring spot actually gives us a distal temperature measurement, whereas the shaft of the pressure wire can measure the proximal proximal temperature. And by giving 3 brisk boluses of room temperature saline, we will see graphs like those in the lower part of this slide. As the colder saline passes through the guiding catheter and along the pressure wire, it'll decrease the temperature at the proximal thermistor, and then it will reach the distal part of the pressure wire, and the distal temperature change will be noted. And the area under these 2 curves have their half points, and the time between those 2 half points will give the mean transit time. And these mean transit times can be measured both at rest and also during hyperemia. And just like in Schwann, which we do in the CCU regularly, we can measure these transit times, and the average of these resting and hyperemic mean transit times will be used for CFR measurements. As I mentioned, about 20 years ago, Bill Fear and colleagues described index of microcirculatory resistance, which is precisely measuring the resistance of the microcirculation. It's an index. It does not have an absolute value. It has a value, but it's not something that we measure in wood units or anything. It's a number. and also it bases itself on the Ohm's law, giving that resistance equals a difference in pressure divided by flow. The difference between pressures entering the microcirculation is the distal pressure and the venous pressure, whereas flow is substituted by the inverse of the mean transit times, and thereby we can arrive at the very well-known equation of IMR equals the distal pressure multiplied by the mean transit time at maximal hyperemia. So this is an index which is specific to the microvasculature, and it specifically measures this lowest resistance index at maximal hyperemia. There are some tips and tricks which we have to keep in mind when measuring thermodilution and thermodilution-based CFR and IMR. The setup is just like FFR measurement. We should use an Abbott wire, previous Senju, or a ready wire, and we should have to place this pressure wire down at least 2/3 or at least 10 centimeters the vessel. The guiding catheter should be kept in a stable position, not too deep, but engaging the orifice, because we have to make sure that the bolus of saline enters the coronary artery. We should not move either the pressure wire or the guiding catheter during measurement. It's important to give 200 micrograms of nitroglycerin intracoronal before measurement to offset changes in epicardial vascular volume caused by flow-mediated vasodilatation. And also, we have to make sure that the bolus of saline that we give will make its effect, because if we could keep too long the guiding catheter stable and we do not flush it before the measurement, of course, it will just warm up because of the surrounding warm blood. So it's important to flush the system first, give the nitro, and then start the measurement. The mean transit time should be measured by 3 brisk injections of roughly 3 mLs of saline. 3 mLs have been found to be just good enough. And of course, for the IMR, for the CFR, we have to keep constant hyperemia. So intracoronary bolus adenosine will not do the job, because of course it will just wean off before we can make the measurement. So either intravenous adenosine or regadenoson or papaverine should be used. This is something that we used to have on our RadiView system previously when using the previous version of consoles. Of course, we have the FFR, we have the distal and also the aortic mean pressures, and then we have the temperature curves at the lower part of the screen, and also the mean transit times both at baseline and its hyperemia. And as shown here at baseline, we have mean transit times of 0.54, 0.31, 0.47, which the console itself will calculate the mean of to be at 0.44, and the same is true for the hyperemic measurements, and hereby we have a hyperemic mean transit time of 0.12. So the quotient of those 0.44 divided by 0.12 will give us CFR, which is given by the console at 3.7. But in this version, we had to calculate IMR by multiplying the mean hyperemic transit time and the distal pressure, which in this case is 9.36. What are the potential advantages of IMR? It's readily available in the cath lab as shown here. It's specific for the microvasculature. It's mostly independent of hemodynamic conditions. It's quantitative and quite well reproducible. And as I show you, it is predictive of outcomes. What are the normal values? Well, actually, we have little data on that, but usually an IMR of less than 25 is considered to be normal. As shown in this slide, there have been a couple of publications on 20 or even less subjects to show that a real normal IMR is below 25. Why is it important? For example, in this publication some 7 years ago, in over 300 patients, all with a non-significant FFR, those with a low coronary flow reserve and a high microvascular resistance had significantly higher rate of mortality, myocardial infarction, and revascularization rates. So of course, it's clinically important. Microvascular dysfunction will actually predict these hard endpoints. So just to illustrate this, I'd like to share 2 cases, one on chronic coronary syndrome. This is a patient, a 71-year-old female who has had Canadian class 2 angina for the preceding 6 months. And she has some risk factors, and her echo is completely normal. The resting ECG is also normal. I hope you can appreciate the negative echocardiograph findings, good left ventricular function, no wall motion abnormality. However, as soon as we stress this patient, she will develop ST segment depression, horizontal ST segment depression. If the patient undergoes SPECT imaging, you will have an irreversible anterior perfusion defect. And an invasive coronary angiography will have some disease in the LAD, in the proximal part of the LAD. So the question is this proximal LAD lesion causing the symptoms and ischemic changes in this patient? Is it diffuse coronary atherosclerosis, which is amenable, which is not amenable to vascularization, but which is ischemia related, or is it microvascular dysfunction? So of course, if you do an IVUS, you will see the plaque with this plaque burden. If you do invasive physiology of the epicardial compartment, you will have a non-significant resting or non-hyperemic pressure ratio, and also a non-significant FFR. However, on IMR and CFR measurement, you can appreciate that this patient has severe microvascular dysfunction, leading to a CFR of 1.3 and a highly elevated IMR of 31. So this is the proposed workup of patients arriving at our cath labs with angina pectoris. Of course, it's invasive coronary angiography. It's the anatomical consideration that should be made first. If it's completely normal, if it has only mild or mildish looking disease, of course, we should sometimes exclude. We should actually always exclude the possibility of a significant epicardial lesion by either resting or hyperemic indices. And if they are exclusively negative, of course, we have to make one step forward by excluding microvascular dysfunction by CFR, IMR, or other indices. I'll show some. And also, another step forward is to exclude the possibility of spasm, which of course can be done by acetylcholine bolus. And also the ultimate step is the endothelial dysfunction, which can be studied by a low-dose acetylcholine infusion. Another case is a patient with STEMI, or two patients actually with STEMI, just to compare those. It's important for us to realize, because microvascular obstruction is one of the key limitations of primary PCI, and albeit the contrast-enhanced CMR is the gold standard to measure this, it's not acutely or readily available. Some patients will have exclusion criteria like claustrophobia or implants, metallic implants. And of course, we have to know this precisely and very early on. So it has been shown a number of years ago by Colin Berry and colleagues that a highly elevated IMR immediately after primary PCI predicts death post-STEMI. We have to realize that in this indication, the cutoff is not 25, but rather it's 40. And some other publications have corroborated this finding. Let's just show you two very similar cases, one in a 57, another in a 47-year-old male, both with anterior STEMI. In both cases, a proximal lesion has been treated by placing a stent with good angiographic result, good flow in both. However, this one has no microvascular obstruction and low transmurality, whereas the other has severe microvascular obstruction and high transmurality. And we could have predicted this by measuring the IMR, which was normal at 18 in the previous and at 46 in the second case. We also know that the IMR predicts peak CK after STEMI, and it's also important in chronic coronary syndrome because IMR measured before PCI will predict periprocedural myocardial injury, and also periprocedural myocardial infarction can be predicted by measuring it immediately after PCI. It's also important for patients after heart transplant. FFR and IMR measured at baseline at 1 year predicted event-free survival in these case series of 74 patients. Of course, numbers are quite low, but there was a very important publication on several hundred patients after heart transplantation showing that an IMR above 18 predicted 1 year allograft rejection, and an IMR above 12 predicted 10-year MACE after heart transplantation. One last remark is on absolute flow. We don't only have the bolus thermodilution, but we also have the continuous thermodilution to give us very exact values on the absolute flow and resistance. In this case, we need specific equipment, and by giving an infusion of 20 mLs per minute of room temperature saline, we can measure the mixture distally of this infusate with blood, and then pulling the pressure and temperature measuring wire back to the microcatheter that actually provides this saline infusion. We can measure the temperature of the saline when entering the coronary tree, and by using this well-known formula, we can actually have exactly the exact numbers of flow and resistance. This is to show you the setup. We not only need the guiding catheter and the pressure wire, but also a specific microcatheter with 4 side holes. And this is the screen that we have with the Corventis software, which gives us not only the FFR, but also resting flows and hyperemic flows and all other indices. And one last remark on microvascular resistance. Bernard de Bruyn and colleagues in 2021 published the MRR, microvascular resistance reserve, for the assessment of microvascular dysfunction. And to put it simply, MRR equals CFR divided by FFR, which is normalized for the change in aortic pressure by the adenosine infusion, which was applied here. And the central illustration illustrates the whole scope of this possibility here very nicely, that we can have all figures in one screen and all important information in one go. So MRI is a new index of the function of the microvasculature. It's independent of the epicardial resistance. It does not depend on myocardial mass. It can be measured fully automatically, making it operate independent. However, it's dependent on resting flow. The normal values are still questionable. We have more and more information. Some labs are working very, very eagerly on this, but we still have limited experience. It has been validated against Doppler fold velocity measurements only so far, and it has a somewhat cumbersome instrumentation. And this very important slide brings us to why we should do all these measurements. It's the Cormica trial to show us that if we apply these meticulous technologies, not only coronary angiography and FFR, but also microvascular assessment, we will have exact diagnosis on what the patient is suffering from. Is it vasospastic angina? Is it microvascular angina caused by the microvascular dysfunction? Or is it completely normal? Did we exclude all the dysfunction of microvasculature, epicardial and microvascular spasm? In that case, we can surely say that the patient has non-cardiac chest pain. And having this precise, personalized diagnosis, of course, we have the possibility of applying personalized therapy to make the quality of life of these patients much better, because we know that they suffer from very low quality of life. And also they keep coming back to all different labs and have their invasive and other tests repeated over and over again, because nobody can give us and give them a precise diagnosis. The importance of these measurements is highlighted by the ESC guidelines back 4 years ago in 2019, giving a class 2A indication with a level of evidence B to guidewire-based CFR endomicrocirculatory resistance measurements if the patient has persistent symptoms and the coronaries are normal or have moderate stenosis with preserved FFR or non-hyperemic pressure ratios. With those, I'd like to thank you very much for your kind attention.
Thank you very much, Joel, for delivering this talk. It's always a privilege hearing your presentation. And as we discussed earlier, so question will be posed after the second presentation. So now, therefore, Youngson, please show your presentation. Thereafter, we will discuss both talks.
So thanks so much for having me. So my name is Youngson Dr. Fan. I'm from China, Zhongnan Hospital of Wuhan University. So the topic of my presentation is computational approach to assess the coronary microvascularization. So first of all, we have to understand the importance of microvascularization. The coronary microvascular dysfunction is quite common in clinical practice. In the routine clinical practice, the coronary microvascular dysfunction is common under diagnosed course of myocardial ischemia, is that yield undeniable clinical prognostic value both in ACS and CCS patients. So why the microvascular dysfunction is so important? Up to 30% of patients continue to have angina despite a successful coronary revascularization, and more than 20% of patients have chest pain and found to have no angiography, apparent coronary artery disease, apparent stenosis. So the microvascular dysfunction predicate adverse clinical outcome in a variety of the clinical settings. So as for the importance of the microvascular secretion, so the patient with microvascular dysfunction, the no CFR, high IMR has significant or high rate of death and microinfarction and revascularization. So why should we assess the coronary microvascularization? So in the first of all, in the patient with normal coronary artery abnormal microvascular dysfunction predicate clinical adverse outcome. So for the patient with chest pain and normal coronary artery, the research demonstrated the microvascular dysfunction was present in more than 20% of patients. The patients with microvascular dysfunction were older and more hypertensive, and more hypertension and more diabetes. So the second, in the stable patient undergoing PCI abnormal microvascular resistance may predicate clinical adverse outcome. So as for the stable angina post PCI, the microvascular dysfunction predicate patient continue to have unstable angina despite after successful coronary revascularization PCI. As for the PCI after the stable angina, the microvascularization measurement after PCI can correct with the troponin release. And the other research demonstrated the IMR, the high IMR measured before PCI in stable angina instead of ongoing LD PCI can correct it with the pure operation myocardial infarction around the PCI. The third, intermediate after STEMI case, the impaired microvascular infarction predicate clinical adverse outcome. This research demonstrated the higher IMR index can predicate the microvascular dysfunction can predicate the peak safety. It can be in patient with the STEMI case after primary PCI. And after the primary PCI, the STEMI case, the research demonstrates that the high IMR can predicate the patient will be improved the nephroventricular function after STEMI. And this research demonstrates the IMR and the microvascularization can correct with the CMR assessment after of the microvascular dysfunction after STEMI case. This research demonstrates as for the STEMI case, the IMR was an independent predicator for the long-term adverse outcome. And this first, the cardiac transplant patients impaired myocardial dysfunction can predicate adverse outcome. This research predicates the myocardial dysfunction with heart transplantation was an independent predicate for the long-term death and transplantation, but where the adverse parameters were not. So there are so many long-invasive approach to assess the myocardial dysfunction. Several non-invasive physiology approach to assess the coronary myocardial dysfunction has been developed, but their use in clinical practice has been very limited due to the technique and the logical drawbacks. As for the invasive approach to assess the coronary myocardial dysfunction, IMR is the invasive estimated myocardial resistance. IMR has been shown to provide prognostic value in several clinical settings. It's generally believed that IMR is the gold standard for the microvascular resistance. However, its use in daily practice is globally very low due to its limitation of the IMR. The limitation of the IMR, including its invasive interpatient variability in independent and epicardial. So because of the due to the limitation of the wire-based IMR, the application of the IMR to assess the state of the microvascular resistance is complicated, and many factors due to the measurement process will have major impact on the test result. Therefore, the IMR cannot be widely used, applied in our CAS lab, the workflows in our routine practice. So to overcome the limitation of the invasive and non-invasive approach I mentioned above, so different angiography-based and the solution to have been proposed and validated and against invasive and against IMR based on the computational flow analysis and only shown, but this research can only show in the moderate accuracies in detecting coronary microvascular dysfunction. As for the representative performance MR, based on the only one single angiography view, the single view UQFR and the flow velocity could be calculated in within 1 minute, and a new physiology parameter to assess microvascular dysfunction could be obtained simultaneously. So the MR will have to detect the MR between the correction between MR and the IMR. So to our best of our knowledge, is that's one of the largest available validation study on angiography and derived MR, and including more than 215 vessels. So this research demonstrates the AMR show good correction with IMR. The linear regression model indicates the quantitative linear relationship between the IMR and the IMR. So the research also indicated the IMR with cut value 2.5 has been shown diagnostic accuracy compared with the wire-based IMR as a standard reference with cut value of 525. So for the reproducibility, the observed reproducibility in dispute and extended correction and absolute agreement and blend analysis, and didn't identify systematic difference between the different analysis and with mean difference. So that's the case presentation. The IMR, the wire-based IMR was 20, and the AMR, the angiography based derived microvascular resistance was 2.054. So that's the case one is a male STEMI case. The wire-based IMR was 48. The AMR was 40.27. The second case is female CCS case. The IMR was 19. The AMR was 1.91. So as for the research, as shown in our research, the sensitivity of the AMR was not significantly influenced by the West type among the LD, circumflex, and RC. However, the specificity of the AMR was significantly lower in patients with STEMI case than the non-STEMI case. So the microvascular dysfunction can readily assist in system and in CAS lab. It's practically of the outcome in certain clinical settings. Whether assessing the microvascular function can alter treatment and lead to improve outcomes remain to be proven. So microvascular resistance can be probably derived by angiography with no need for dedicated pressure wire and hyperemic condition. So in our validatory study AMR yield clinical use for diagnostic accuracy in detecting CMD in different clinical settings as wire-based AMR as reference. So the new parameters AMR proactive provide validate, reproducible, and fast computational or to wire-based AMR in routine clinical case lab workflow. So that's work. Thank you.
Jens, and thank you very much for your talk. And so I invite now questions from the audience. I would like to also ask my co-chairman, Zsolt Kószegi, to lead the discussion. And probably you have also questions, Zsolt.
Okay. I haven't seen any chat question, but meantime, I would ask Zsolt what is his opinion and IMR measurement by intracoronary adenosine. Of course, it was not accepted because there is no enough vasodilatation effect. However, there is a recent publication which showed a successful application with repeated bolus adenosine, which would decrease the complexity of the procedure. What do you think?
Well, thank you very much for this question. I think this is something, one of the Achilles heels of IMR measurements, that we have to have constant hyperemia. And to be honest, even though we stated that IMR is highly reproducible and it's independent of human conditions, as we advance in the field and as new indices appear, we can appreciate that this is not completely true, and that IMR has some operator dependency. The repeatability is far from being ideal. And one of the reasons is probably related to the incomplete and fluctuating hyperemia during the measurement. So albeit it's a very welcome finding that repeated boluses of intracoronary adenosine could make up for this, but I don't think that this is a way to go. And leading experts in the field actually have other indices already in mind to describe the microvasculature and its function with high precision reproducibility. So I think, yes, in reality, intravenous infusion of adenosine is cumbersome. In our labs, we use 90+% of IC adenosine for our everyday measurements. But of course, these are FFR measurements. We are less and less likely to use IV adenosine, but it's useful. It can be used. It's not such a big deal. And also we have papavernitan, which is quite good and which will give us 30 to 60 seconds of constant and full hyperemia. So honestly, personally, I would not use intracoronary bolus of adenosine in regular case. Of course, we see patients who have long-standing hyperemia after a single bolus of adenosine. There are those who actually have their lazy erythrocytes, which they degrade adenosine very slowly. And in these cases, you may have, say, 20 or even 30 seconds of hyperemia sometimes. But you know, when you do an IMR measurement, sometimes the machine is not able to pick the first measurement because the transit time is outside of the window. So it says you have to repeat it. So to have 3 measurements completely done and repeatably done, well done, with just intracoronary bolus, I don't think that that's the way to go, honestly.
Thank you.
So can I ask a question?
Sure.
So can I ask a question to Dr. Zsolt?
Yes.
So I have to pay attention on the MRM measurement. So can you tell me something about the difference between the IMR and the MRR? That's the first question. So nowadays, we can't perform the MR measurement in China. Do you have any experience in the MR measurement? So
you can actually perform it.
Yes, is the MR measurement. So how do you think the future of MR?
Yeah.
Thank you.
Thank you very much for this question again. Actually, you can perform because it's not a vendor-related issue or nothing that you require specific measurement. If you are able to measure IMR, of course. So MRR is specific to the microvasculature. It takes into account the fact that if you concentrate on microvasculature, but have some epicardial disease, of course, you will have some resistance in the epicardial compartment. And just if you read that article, it's a beautiful mathematical derivation, how you actually can impute the importance of epicardial resistance and actually arrive at the equation that MRR equals CFR divided by IMR, by FFR times the aortic pressure at rest divided by aortic pressure at hyperemia. Because if that does not change, if the aortic pressure is the same during hyperemia and resting conditions, then the equation is simply MRR equals CFR divided by FFR, and you can measure CFR and FFR. So it's just the fact that it's completely specific to the microvasculature. It's really operator independent, and it's very, very reproducible. It has been validated against just a couple of non-invasive techniques like PET, but the widespread application is yet to be seen. But the mathematical background is very convincing that it's really specific to the microvasculature, and it's not really specifically needing anything important. The absolute flow measurement, of course, is something more demanding with the microcatheter and the infusion pump, and also the Corventis software. Here it's different. You don't need absolute flow measurement to have MRR. You can measure it with your bolus thermal dilution, provided you are able to measure a CFR, not only FFR. But the idea is to be specific to the microvasculature and being operator independent and thereby well reproducible.
Thank you. I agree. So I think the MRI measurement can overcome the limitation of the IMR, the application of the MRI assessment to the state of the microvascularization is really, really complicated. So many factors during the measurement process will have major impact on the test result. So I think the MR can overcome the limitation of the IMR. It's more reproducible. Thank you.
Thank you.
I would like to ask Zam,
yeah.
in your approach, you use the resting contrast traveling velocity for the calculation of the maximal hyperemic state resistance. So I think it can be done by an extrapolation using a database which shows the average increase of flow velocity. How can explain it conceptually that the resting data will be enough for measuring the hyperemic conditions, which is an individual reaction of the microcirculation? And don't you think that using the hyperemic contrast velocity can improve the accuracy of the method?
Okay, thank you. So it's a good question, but it's hard to answer. So the AMR, the angiography-based microvascular resistance, is just based on only one single angiography used. The QFR and the flow velocity could be calculated within 1 minute, and the neurophysiology parameters can assess the microvascular dysfunction. Could be obtained simultaneously. So I think it's the advantage, but it also have but I think it also have some limitations based on the pressure drop and the distal coronary pressure PD of obtain and the UKFR was and the compute the divided by the meaning outer pressure, the PA. So while the MMR is computed as the divided by the hyperemic flow velocity. So it's hard to answer. But I think it also have some limitations. We didn't have the follow-up data for the AMR. Thank you.
Okay, I just think that the contrast material during adenosine also can be acceptable sometimes because it's not so big burden for the patients, and theoretically it has more information than the resting velocity. Thank you.
I think. Thank you.
Also, if I may just make one remark, I'd like to kind of highlight the fact that if you have information already that you can apply in making some measurements or calculations with respect to the microvasculature without any specific instrumentation or any specific drug needed, I think that's a major step forward in making it more readily available to others and making other people pick up this technology and realize the importance of microvasculature. Honestly, I think we'll need a lot more data to show that these findings are generalizable. And as you showed, that the reproducible or even specificity of your measurement is as less in STEMI cases as compared with chronic coronary syndrome cases. That already brings up a lot of ideas why this is so and how it may be different in different scenarios. But in reality, if you have data which is just there, because we all do angiograms just to have our roadmaps. And if we can use those pieces of data, we can at least pick up some patients who have very severe microvascular, or at least signs of very severe microvascular damage that probably are good candidates for specific targeted therapies. Or in others, it's completely normal. It's very unlikely that an invasive measurement would make a difference. So this way, we can actually lessen the need for real invasive measurement of the microvasculature, which of course, in borderline cases, should be and should remain the diagnosis of the standard diagnosis.
So is there any clinical data on outcome as a follow-up for MRR? So data for outcome?
Not yet. No, the whole thing has been described a little more than 1 year ago, so I don't think that anybody has done any on this. At least I'm not aware of anything. But of course, it's I mean, if you have the data of your previous measured CFRs and FFRs, it's easy to compute because it's nothing specific that you have to do. It's just a calculation. You also have to have the aortic pressures at rest and hyperemias, but you can do this. You can create databases, but I'm not aware of any long-term outcome of any patient groups with respect to MRR.
Actually, I saw a preprint which published for MMR prognostic value using before database, and it is stated that as a kind of agnostic index can be used, as you mentioned, because the MMR can be applied for any technique which assess the CFR and the pressure. And they found that the MMR had a much better prognostic value in that population than the CFR, which is quite understanding because it's much more specific for the microvasculature than the CFR itself. Okay. Do you have any question or remarks, or can we see question from the audience?
So I cannot see any question from the audience, but actually it's just a practical question regarding the assessment of the microvascular circulation in acute settings. Do you think that are there differences between the techniques in case of MI, if you would like to really assess the outcome of the treatment for MI? So regarding the microcirculation, can you see, and also with the timing, what is the best timing to do these measurements, or are there any differences between the measurements for timing after MI?
Well, if I may take that, I think the reports that have been published so far are all on immediate measurements after primary PCI. I mean, it's just the easiest because you have the patient on the table, the guiding catheter in place, you have the wire. So if you just after primary PC, after opening the vessel, just pass a pressure wire and make measurements, you have a very early chance of identifying those at highest risk. So even if you have a good angiographic finding and a good blush score and so forth, as I showed you by the 2 cases, you can find those who are at high risk of heart failure mostly, and therefore you can start thinking about specific therapies. Of course, we have nothing specific in hand, but we only have even more intensive care. You can think of giving as much ACE inhibitors or even ARNIs as possible. You can start thinking about SGLT2 inhibitors or MRAs and so forth. So in order to prevent later heart failure, and we can also think about different drugs to prevent microvascular obstructions. We have at least 20 agents that have been tried so far, and also just a couple of weeks ago, Nico Pels presented the EuroEyes trial, and the specific localized hypothermia trial, which actually was negative. But again, we have important movement in the field, in the sense that we are trying to target microvascular obstruction and low flow or slow flow phenomenon. And I think at least the very measurement is something, a tool that we have in hand, which we can apply to have a quantitative measure of the different therapeutic options that may come up, and we can compare those. So of course, that's my answer. The best thing is probably to do it immediately after primary PCI. Whether to repeat it a couple of days later will have important add-on information in terms of prognosis. We don't know.
So then we can see also delta, so the changes between, but with all of the method, this is suggestive. So making directly after and
maybe the microvascular dysfunction for the STEMI case after the primary PCI can recover after 1 week or after 1 month. Do you think?
Yeah. Yes.
Yeah, this is what I think that is it
possible.
maybe. And actually, if you can compare the after the PCI and also maybe the initiation of the different therapies that you selected based on the results, and to see the deterioration or the development of the disease, or just you can also predict the progression better. Okay.
Yeah. So it also can predict the clinical adverse outcome.
Thank you.
Thank you.
So I think it's time now that Zsolt can summarize the talks that we had, and you have also some presentation.
So just a short summary, dear colleagues. I think we could hear a very high-level and informative lectures about microvascular function assessment. We know that invasive coronary angiography shows only 10% of the coronary vasculature, and 90% is in a kind of black box. However, in this webinar, we could hear some very exciting methods to open this black box. And Zsolt described the invasive opportunities for the classical IMR measurement and the new continuous thermodilution method, which has, of course, a great advantage, but we have to notice that it requires a dedicated infusion catheter also. The non-invasive or less invasive image-based assessment was validated against invasive measurement, and it has such an advantage, of course, that it does not require invasive flow or pressure measurement. However, let's investigate the limits of agreement between the reference method with some NGO-based methods, and we can detect quite high limits of agreement. In percentage, it can reach even a minus or plus 100%. when we use only angio-based approach. There are two publications which use the intracoronary pressure to incorporate the calculation, and it reached significantly lower limits of agreement with other reference method. In that case, it was Doppler. So I can see that, I can imagine that it also can be a way, but what was a very important advancement in this field, which was presented by Bernard de Bruyn in 2020 in the AHC Anders Grünsig lecture. It was the microvascular resistance reserve by continuous thermodulation. But as we discussed, it is not specific to apply to this technique, but any technique which calculates CFR and pressure, it can use this very new concept. So regarding that, Bernard de Bruyn was one of the inventor of the FFR. I can imagine that this MMR concepts also will be a very important step in the history of intracoronary physiology measurement. So the concept was detailed. The alternative, the similarity of the FFR can be accepted because we have to use a theoretical normal artery for the relation of the resting resistance, and in that way we can very specific index which represents the microvascular vasodilatory capacity extrapolated to the region supplied by a normal epicardial vessel. So thank you for the speakers and the audience for the attention. And I would like to say goodbye with the opportunity that this Journal of Personalized Medicine still accept submission in this topic. Thank you.
Thank you very much. We are way in time. So
okay, and just for the end, I would like to, on the behalf of our journal and on behalf of MDPI, to thank every one of our speakers, our chairs, and all of the attendees.